all distinguished guests, ladies and gentlemen, Assalamu alaikum and a very good morning. As a moderator, I must introduce myself. I am Dr. Noman Karim Qureshi and currently I am working as a consultant gastroenterologist and hepatologist in Sheikh Zayed Hospital, Muzaffarabad, Azad Kashmir. Also, I am the regional representative of Pakistan Society of Hepatology for the region of the North. On behalf of Pakistan Society of Hepatology, I warmly welcome you all in this morning session of the second day of 22nd Annual Conference of Pakistan Society of Hepatology. As you already know that this session is about paper presentation and quiz. So first we will have paper presentation and then we will move to quiz competition. We have some well-renowned gastroenterologists here with us who are chairing the session. We are highly indebted for their valuable presence. Our first chairperson is Professor Dr. Badr Fayaz Zubairi. He is the head of medicine department at Dow University of Health Sciences. He is also fellow of American College of Gastroenterology and member of European Association for Study of Liver Diseases. Our second chairperson is Dr. Numan Zakir. He is the consultant gastroenterologist and hepatologist at PKLI, Pakistan Kidney and Liver Institute. So now moving to paper presentation, remember the rule that presentation has to be finished within 8 minutes. As we know, the WHO has set an ambitious target to eliminate hepatitis C virus by 2030. Pakistan is one of the focused countries because of high prevalence of hepatitis C infection. And to reach that goal, public awareness is very important. So first topic is viral hepatitis and liver diseases in Pakistan, a sub-analysis of Asia Liver Index study. It's going to be presented by Dr. Asad Chaudhary, who is the Director, PARSA, ECO, Pakistan. Sir.
Thank you. Thank you very much. Bismillahirrahmanirrahim. Very good morning to everybody. This is a study which was conducted in around 11 countries in Asia through Gilead. Interesting one. I just wanted to share here and may not be representative of the whole Pakistan, but still. So what we did was, you know that viral hepatitis is a global health problem with varying prevalence, transmission pathways and pathogenicity. You know about the prevalence of Pakistan and a high rate of prevalence in this area. It's highly endemic in Pakistan with nearly, I think, 10 million infected, and prevalence as per 2008, it was 4.9% and 2.4% for C and B respectively. So it's a real-world, cross-sectional online survey across 11 countries, regions in the Asia-Pacific region, prudently designed scoring system such that the general population awareness and knowledge could be assessed and compared across the region, and the areas for improvement could be identified. And this sub-analysis was a part of the real-world survey, with the objective to assess the awareness, knowledge, and attitude of the population of Pakistan towards liver health and liver disease, mainly viral hepatitis, to help influence a positive behavior change and ultimately aid in evaluating current policies and implementing further policies to reduce the burden of the liver disease. It was a sub-analysis of a cross-sectional online survey from 1st February 2020 to mid-March 2020. 500 respondents from Pakistan, 52% males. Awareness, knowledge, attitude, and stigma towards the liver disease were assessed using section indices comprising of relevant questions in various sections of the questionnaire. The overall liver index was calculated as a weighted average of the different section indices for Pakistan. Additional analysis, which include multi-level modeling, multivariate analysis, and subgroup analysis, were also performed. Overall, the awareness of Pakistan was not bad, and compared with other countries like Taiwan, Singapore, Hong Kong, India, Bangladesh, Nepal. So Hep B, 83% were aware. Hep C, you can see it's around 80%. Participants from Pakistan exhibited notably high awareness of different types of hepatitis. 8 in 10 participants had heard of hepatitis A, B, and C. Awareness of hepatitis C was the highest in Pakistan amongst all countries. Hepatitis B could be transmitted by sharing non-sterile needles. 9 in 10 people agreed. B and C could be transmitted by sharing of razors, toothbrushes, as well as through blood. At least 8 in 10 people agreed. Hepatitis B or C could be transmitted through sexual intercourse. 6 in 10 people agreed. Limited knowledge on certain facts and myths was seen. Hepatitis B and C is not transmitted through mosquito bites or by dining together with an infected person. Only 4 in 10 agreed. Viral hepatitis B and C is not transmitted through fecal or oral route, through contaminated food or eating contaminated and raw seafood. Only 2 in 10 agreed. So here is a knowledge in different aspects of B and C. I'll focus more on C here. You can see 57% thought it's a bacterial infection, 50% thought it's a viral infection. A lot of people knew it's a chronic inflammation of the liver. 86% knew it can cause liver failure. 80% said there is a vaccine for hepatitis C. 28% felt it's an airborne disease. Hepatitis C is hereditary, 37%. Hepatitis C increases the risk of development of liver cirrhosis and cancer. 80% of the people responded positive to that. And then there was some Pakistan-specific questions and responses. 2 in 10 people were extremely unlikely to have dinner, work together, or get married to someone diagnosed with hepatitis B and C. And you can see the questions we asked: are willing to have dinner with a person, do not mind to work together with a hepatitis person, and would be concerned to get married with a person diagnosed with hepatitis B and C. The top 3 ways of receiving disease information in Pakistan included doctor consultation, internet forum, and internet search. And then other thing, mobile phone apps, patient disease awareness, family and friends. You can see a breakup here. 5 in 10 people, they sought treatment at medical specialists for treatment of any liver disease. So around 56% for medical specialists, gastroenterologists, hepatologists, primary care physicians, private general practitioners, 44%, and you can see around 30%, 35% from government-run clinics. 5 in 10 people were aware of the National Hepatitis B vaccination program, which aims to prevent and control hepatitis B. So we need to work a lot on this. It is an outline of the efforts of Pakistan and investment in elimination of hepatitis, viral hepatitis. Just go ahead. So the need, gaps, and their solution. Although people in Pakistan had the highest knowledge and association of modes of transmission of viral hepatitis, gaps in knowledge, they still exist. There is an immediate need for educating and creating awareness regarding transmission myths across the entire country. Multiple awareness campaigns and activities to effectively reduce burden of hepatitis B and C, early diagnostic and treatment intervention. Substantial efforts are vital for reaching the WHO HCV elimination target in high burden settings in Pakistan. Healthcare professionals play a crucial role towards eradicating hepatitis C. Prevention, intervention to significantly reduce the disease burden, strong political and financial commitments and support from all the stakeholders, pharmaceutical, academic, and civil societies. Initiatives like Project ECHO to reduce chronic hepatitis C burden. So in conclusion, an overall significantly high level of awareness, good knowledge and attitude towards liver health and hepatitis B and C was seen. However, the high burden of chronic hepatitis B and C still imposes a challenge for the community, healthcare providers, and the government of Pakistan. Further dedicated efforts are needed to tackle this issue. So my last comment is, this was mainly carried out in the big cities of Pakistan: Lahore, Karachi, Islamabad. The people who had online interviews, they were higher income strata, as you would have imagined, and their education qualification, only 10% were below metric. So, they were higher educated. So it may not be that representative of the whole of Pakistan, but nevertheless, we have some information on that. Thank you. Any questions?
So, obviously, we know that our education literacy rate is low. So, obviously, we have missed a lot of them, which you obviously pointed out that there is a limitation in your study. And it was an online service, so obviously, internet literate people will be involved in the study who are willing to answer those questions as well. So, nice, thank you.
Yeah, that was the biggest concern, and we were designing this, so that was my biggest concern because of the 11 countries. We have 500 participants from Pakistan in this. I think only India and probably China had 1,000 participants, but otherwise all other countries, they had 500 participants each from a country. So that was a concern, but that's how they could only ensure this. Thank you.
Thank you, Dr. Asad. Before moving to next talk, we welcome our third chairperson, Dr. Nazish Bhatt. She is an associate professor and head of gastroenterology and hepatology department at JPMC Karachi. She is also vice president of Pakistan GI and Liver Disease Society. Now, caustic ingestion is a grave public health problem which causes severe morbidity and mortality. Initial evaluation of severity of injury is very important to guide the further management. So our next topic is neutrophil to lymphocytic ratio as a predictor of endoscopic damage in caustic injuries. It will be presented by Dr. Nabil Shafkat, who is PGR at DHQ Hospital, Gujranwala.
Assalamu alaikum. I am Dr. Nabil Shafkat. Today I am going to present neutrophil to lymphocyte ratio as a predictor of endoscopic damage in caustic injuries. These are the co-authors of my study. When we look at the background, the ingestion of caustic substances is a medical emergency, and endoscopy is recommended as a diagnostic as well as a prognostic tool. It is the first test to be done. It is a considered as a gold standard test, but it is very expensive. Endoscopy is usually done as early as possible within 24 to 48 hours after the ingestion. And during endoscopic procedures, the Gars classification is most commonly used to grade the mucosal injury in esophagus as well as in gastric mucosa. Neutrophil to lymphocyte ratio is used as a marker of inflammation in many diseases, and it has been studied in different centers to use the neutrophil to lymphocyte ratio as a marker of inflammation in patients with previous caustic ingestion. The objectives of our study was to determine the values of neutrophils to lymphocytes ratio of patients with corrosive injuries and to assess the correlation of these inflammatory markers with organ involvement and degree of injury. It was a cross-sectional study carried out in gastroenterology department of DHQ Teaching Hospital, Gujranwala from 1st January 2021 to 31st December 2021. A total of 180 patients were included in the study in between the age of 14 to 60 years, all presenting with caustic intake. Endoscopy was performed within first 24 hours in dedicated endoscopic suite, and a structured endoscopic protocol was followed. The esophageal and stomach mucosal injury was graded into low or high grade by using Zergar's classification. CBC sample was also done within first 24 hours for analysis of neutrophil to lymphocyte ratio. The association between neutrophil to lymphocyte ratio and endoscopic findings were evaluated. Looking at the result, if we see at the distribution of gender, grade of injury, suicide, and substance used for suicide, it is very evident that 76.1% of the patients were female. And if we look at the cause, most of them, approximately 84% of the patients was due to the suicidal attempt, and only 16% of the total population had a corrosive ingestion by error. 80% of the patient used acid substances. The possible relationship of grade of injury with or without suicidal attempt, if the ingestion was due to the suicidal attempt, 89.1% of the patient had higher grades of injury in esophagus as well as in stomach, while in case of by ingestion by error, only 77.2% had low-grade injury. So the suicidal attempt by itself is a high-risk factor in corrosive injuries. Comparing the NLR between low and high-grade injuries, our study concluded that low NLR ratio of 5 plus minus 2.5 was correlated with a low degree of injuries in esophagus and stomach, while in NLR ratios of 10.1 plus minus 4.6 was associated with higher degrees of endoscopic injuries. Receiver operator curve, the area under the curve was 0.838 with a statistically significant value, and the cutoff values at 3, if we use the cutoff value of 3.5, the sensitivity was 96 and specificity 63%. And if we increase the cutoff value up to from 4.5 to 5.5, the sensitivity and specificity decreased. However, the sensitivity of 75% was still high. So concluding, NLR values are predictive of grade and severity of corrosive injury. High levels of NLR indicate severe caustic damage, extensive involvement, and the likelihood of developing complications with high sensitivity. A low NLR may be directive in deciding a hospital discharge. Thank you.
Well, Nabil, your study is an exciting one. Seeing so many high numbers of corrosive agents in your district hospital again raise the questions that why in the population so much of these corrosive injuries are occurring, that as another topic to be looked into. What can I have the conclusion slide? कंक्लूजन की स्लाइड लगा दें. You see, you cannot make conclusions for which an objective has not been achieved, has been made. So your objective was different and your conclusion was different. So you need to correlate both these two. Right? Like, भाई आखिरी स्लाइड हुआ यार. Predictive. ये वर्ड आप कहाँ से ले आए, जबकि आपके कहीं ना ऑब्जेक्टिव में था ना टाइटल में था. ठीक है ना, है ना? तो प्रेडिक्टिव, हाँ, लेकिन जो आपने अंदर टेस्ट, सॉरी, आपने जो अंदर मेथड लगाया है वो आपने पी वैल्यू लगाई है कंपैरिजन की, कि जिन्हों के अंदर वो सुसाइड अटेम्प्ट थी या नहीं थी. तो वो तो सिर्फ डिफरेंस इन द वैल्यूज और मीन्स के लिए, कोई प्रिडिक्टिव का टेस्ट कहीं भी आपके उसमें मेथड्स में नहीं था. So you need to employ the statistical methods that can give you a prediction model rather than just to see the difference in mean values with the, okay, whether this one is that, that only shows the difference between the
high grade injury, low grade injury with high or low mean value of NLR.
आपने लगाया टी टेस्ट, तो उससे यही पता चल रहा है कि भाई इसके अंदर फ्रीक्वेंसी ज़्यादा है, इसमें कम है, इसमें मीन ज़्यादा है, इसमें कम है. तो प्रिडिक्शन जो है वो, जो आपका टाइटल और जो आपका कंक्लूजन है वो अचीव नहीं हो रहा आपके मेथड से. तो मेथड को थोड़ा वैग करें या इसको ऑब्जेक्टिव को चेंज करें, तब ये किसी अच्छे जर्नल में जा सकेगा, नहीं तो ये इसी जगह पे निकल जाएगा. ओके,
थैंक यू.
Just want to add one thing. I'm shocked at the number of corrosive intakes in your hospital. I'm shocked. I think one more thing that you probably you can do as a medical professional and as an advocate to the patients, all the females in your district or in whole of Pakistan, is to start some kind of movement that the selling of acid should be outlawed to general public?
Yes, we are working on this because in Gujranwala the incidence of corrosive intake is very high, and we are currently working on to do some social media campaigns about it, so that the corrosive intake as well as the use of weed pill should be stopped. It should not be available easily in the market, so we can reduce the burden of these two diseases. So, we are currently working on this. How can we create some project and educate the people about it, or decrease the availability, so easy availability of these substances in the market?
Just like this, like I can tell you that I know that corrosive intake is the main bread and butter of gastroenterologists in government hospitals, in endoscopy section especially. But likewise in UK and US, paracetamol overdose is the main thing. And what they have done in UK is never to give more than 2 strips of 10 tab paracetamol each whenever they go, anyone wants to buy paracetamol. So they have made it mandatory under a law actually. So you have to work not just with public, that's good, but with the lawmakers. Lawmakers can make all kind of flimsy, laws, as you know, but this is important.
Revelation that, at Sheikh Zayed, very similar experience. Per year, we were having more than 200 patients coming in with corrosive intake. And I did, we did a survey and we wrote a paper as well, and we did make some recommendations at the level of Society of Gastroenterology at that time. Like you said, it has to be awareness, public awareness, as well as legislation. Probably you don't know that corrosives in our country are not regulated. The alkalis are of very, very high strength. So instead of 10% strength that is permissible in the West, these here are from 30 to 70%. So number two, they are very cheap. They are available in every domestic setup. People don't have money to buy things to commit a suicide. They just go for cheap things which are readily available. And that was the reason that when we analyzed our data, that is what we found, that availability, cheap, very effective in destroying everything and even killing, these were the main reasons. And we did make recommendations about that. Legislation to control the strength of the corrosives available. They should have a special packing, child-proof. They should not be in attractive colors to, the children go to try and play with it. So all this was made maybe 10 years ago when I was at Sheikh Zayed. So, an effort has been made in this regard. But as you rightly pointed out, there are a lot of problems in this area, and these have to be addressed. Nazish, you wanted to say something?
Nice effort, Noman. Have you find any difference between alkali and acid related corrosive injury?
Yes.
In the ratio, related with the ratio?
Yes.
Which one is high, which one is low, or any?
No, we didn't focus that aspect of the injuries. But overall, the result indicated that the alkali affect more the gastric mucosa, and acidic injuries were more common in the esophageal.
It's
but
already known, but I am talking about
yeah,
this
we didn't
ratio.
focus that in the ratio of NLR.
Okay.
Thank you, Dr. Nabil. Thank you. Acute and chronic liver failure has emerged as a major cause of mortality in patients with chronic liver disease. It is a challenging condition with rapid clinical course and high short-term mortality. So moving to our next topic, which is incidence, grading, and mortality of acute and chronic liver failure according to Easel-Cliff criteria. It will be presented by Dr. Sulaira Khan, who is PGR at JPMC Karachi.
Assalamu alaikum everyone. I am Dr. Sulaira Khan, postgraduate trainee at Jinnah Postgraduate Medical Center. And the topic of my presentation today is incidence, grading, and mortality of acute and chronic liver failure according to the Easy-Cliff criteria. Introduction. Acute and chronic liver failure is characterized by acute decompensation of liver in patients with pre-existing chronic liver disease. This condition presents as jaundice, deranged INR, or extrahepatic organ failure resulting in early death. It was a prospective cross-section study carried out for 6 months at Jinnah Postgraduate Medical Center, and all patients with CLD who consented for the study were included. However, the patients with major comorbidities who denied consent and the patients with the missing data were excluded. The results of the study showed that we had 55% of the participants as male, with 45% as females, and the overall mortality and further grading the patients according to the Easy-Cliff criteria, we found out that 29% of the participants met the ACLF criteria according to the Easy-Cliff criteria. Further, we graded the patients into the ACLF grade 1, 2, and 3, with 105 participants in the non-ACLF group, 24 participants in the ACLF grade 1, followed by 13 in ACLF grade 2, and 6 participants in ACLF grade 3. We had an overall mortality rate of 21%, with 79% of the participants being successfully discharged and 23 participants undergoing a fatal fate. On further analyzing the results, we found out that the mortality rate in the ACLF group was 24%, which was twice the size of the mortality seen in the patients with the non-ACLF group. On correlation between the CTP and the ACLF grading, we found out that only the patients in the ACLF grade 1 presented to us with the CTP, in ACLF grade 1 presented to us with the CTP class A. However, the patients presenting to us with ACLF grade 2 or ACLF grade 3 had decompensated chronic liver disease according to the CTP classification. The mortality in the ACLF grade showed that 100%, there was 100% mortality in ACLF grade 3, and followed by ACLF grade 1 with 17% mortality and 0% mortality in ACLF grade 2. The association of ACLF with the organ failure showed that the patients with ACLF who presented to us, majority of them had renal failure, with 60.5% of the participants in the ACLF group and 0% participants in the non-ACLF group, followed by cerebral failure seen in 46.5% of the participants in the ACLF group and 23.8% of the participants in the non-ACLF group. It was also seen that the major cause of admission in majority of our patients was hepatic encephalopathy, followed by upper GI bleed. The conclusion. It is important to identify acute and chronic liver failure and differentiate it from mere acute decompensation, as management and prognosis of both groups differ significantly. It is seen that patients identified early with 2 or more organ failures at presentations can be planned for aggressive management and an early decision for liver transplant in order to reduce the mortality. Questions?
We've got just 2 minutes for the questions. So any question? Yes. Of acute viral hepatitis. It is endemic in Pakistan. So our fourth and final topic is rising hepatitis E infection in Pakistan and need for hepatitis E vaccine. It will be presented by Dr. Andreeb Arai, who is PGR at AIMS, Hyderabad.
Assalamu alaikum. Thank you all of you, and Assalamu alaikum. Thank you all of you, and I am Dr. Anleep, second year GI resident at Asian Institute of Medical Science, Hyderabad. Today my abstract topic of presentation is rising HIV infection in Pakistan and need for HIV vaccine. Below mentioned people help me in data collection, and my mentor, Dr. Professor Sadiq Mehman, also helped me. Next. एरोस का है नीचे वाले outline of my objective outline of my abstract is first, according to WHO, HIV infection is a global problem affecting 3.7 million people each year by HIV infection with an estimated annual mortality of 70,000%. Pakistan is the endemic country for HIV infection. In 2002 reported HIV past infection in chronic liver disease and control population of Pakistan is about 17%. We thought that HIV infection is rising in Pakistan, not in chronic liver disease, but also in control group. We have checked our chronic liver disease patient with a recent rise in HIV incidence and before vaccination for the past exposure of hepatitis E infection and compared it with control group. Aims of our study is to evaluate the prevalence of past exposure of HIV infection in chronic liver disease and healthy volunteer. To evaluate the need for vaccination for chronic liver disease patient who already had the evidence of past exposure to hepatitis E virus infection. We prospectively checked the anti-HIV IgG to consecutive chronic liver disease patient and a group of healthy volunteer. The chronic liver disease were further divided into 4 groups: chronic hepatitis, compensated cirrhosis, decompensated cirrhosis, and hepatocellular carcinoma. This is an outpatient office-based study conducted from Jan 22 to May 22 in hepatology clinic at Asian Institute of Medical Science. A total 196 participants were enrolled in study. 162 were the chronic liver disease patient and 32 were control group. A total 136, 69.4 participants were reactive to HIV IgG. Highest prevalence of HIV IgG was seen in decompensated, about 75.7%, and least in the chronic active hepatitis is about 58%. Weird surprisingly, the control have the same frequency of prevalence of HIV IgG, about 65%. The control and chronic liver disease were matched in age and gender. There was no statistically significant difference in past history of genders, severity of liver disease, and comorbid of HIV infection are non-reactive patients. This is the different groups of people involved, and the table shows that more or similar, all groups have the same prevalence of HIV infection, about 60 to 75%. History of jaundice is also not significant in both groups. There is no any significant difference in age and gender, about little bit difference in both positive and negatives. At the last conclusion, the population of Pakistan in 2022 has a very high prevalence of HIV IgG. Past exposure about 70%. There is no difference in frequency past exposure in chronic liver disease and control population. While making guideline for the HIV vaccine, one must keep the highest prevalence of HIV infection in mind. Thank you.
We got just 2 minutes for questions.
ठीक है.
The topic was very relevant. What I wanted to inquire is that as a practicing gastroenterologist, we have seen that there is a high mortality of hepatitis E, especially in pregnancy. So have you, in your inclusion criteria, have you included or have you thought about including the patients who were pregnant, because there is a high mortality related to hepatitis E in pregnancy?
Yeah, high mortality in HIV infection in pregnancy, but I am not included in our study because 2 to 3 patients are come within a month के HIV infection. But if patient is HIV not in high mortality in pregnancy, early treated, if patient is early treated, but I am not included in my study. In pregnancy, HIV. Just chronic liver disease and control healthy volunteers are included.
Okay. Miss Arai, I again congratulate you for a very nice presentation, but I will request you to kindly remove the word prevalence because you never did a prevalent study in this.
Okay.
In your conclusion and your objective, wherever the word prevalence is comes, you have to remove it, unless you fulfill the criteria of prevalence.
Thank you, Dr. Anleep. Now moving to our last presentation, it is by Dr. Hanisha Kemani. She recently cleared her fellowship from JPMC Karachi. Her abstract is on fulminant hepatic failure, etiology, clinical manifestations and outcome, and experience of tertiary care hospital of Karachi, Pakistan.